This is the Oculofacial Podcast, the official podcast of the American Society of Ophthalmic, Plastic, and Reconstructive Surgery. Since 1969, ASOPers has been focused on the health and beauty of the eyes and face. Whether you're one of the 750 ASOPers member surgeons around the world, another physician, or a member of the public, the Oculofacial Podcast aims to inform you about the past, present, and future of oculofacial plastic surgery. Welcome to TOP.
Welcome back to TOP. I'm David Samimi, oculofacial plastic surgeon at Aesthetica and USC in Los Angeles, and I'm excited to bring you the second episode of What's in Your Tray. If you missed the first one, we talked about functional instruments and tools that help you in the OR and beyond with functional surgery. Today, we're going to discuss the instruments and tools that are great for cosmetic treatments. And this is a segment that's near and dear to my heart. I love aesthetics, and I've learned so much listening to all the different people that we interviewed here in Chicago, and I'm hoping it's going to really be helpful for you guys as well. So let's get this episode rolling and hear from our first surgeon, Kat Burkett.
Well, I am honored to be here sitting next to the person that made this meeting happen, Kat Burkett. Your brain's probably fried, pulled you right off the floor at the end of the meeting, but we could not have you have some representation and hear about the instrument that you love so much. So why don't you tell us where you're trained, where you're in practice. I'm sure everybody knows that, and how long you've been practicing.
Well, thank you very much, first of all, David. I'm pretty fried. I'm actually coming here to talk to you, even though I could be up having a drink somewhere. So that's how important this is, I think. But I trained in University of Wisconsin, Madison, with actually Brad Lemke was my main preceptor, but also Mark Lucarelli, John Rose, George Block was there, and have actually stayed on there since.
They just wouldn't let you go.
I know. I didn't even know where Wisconsin was until I went there. I just knew it was somewhere in the middle. To be honest, I don't even know what states border Wisconsin still. I actually have to look up on a map. I know that Canada's up north somewhere, and Illinois, I think.
They probably like keeping it that way so that there's no chance you'll escape.
Maybe.
Now I see how they did it.
You certainly can't escape the weather either. It's pretty bad. So.
Well, tell us about what it is that is your little secret weapon that you love to use.
Yeah, well, I love this little eyelid crease simulator, they call it, or an eyelid like hook. It's basically kind of like a fancy version of a safety clip. Or a paper clip, basically, that you just open up. So, it's just a way to show patients what their crease height would be and maybe kind of how high, how low. And I actually find it particularly useful for Asian eyelids. So when I'm trying to show a patient with Asian eyelids how they would like to appear later, some people want the epicanthal fold, some people don't, higher or lower crease. And when you show patients' pictures online, sometimes it's not really representative of what they will look like because they're seeing different facial structures and their face is totally different.
The brow volume.
The brow volume, the cheeks. It's like a totally different person. It's like me trying to look like you, and it's impossible. You're too good looking. So,
go on. No, let's go back to that.
Okay. So basically, I will show them this, and it's just this little metal hook that kind of curves. It's not sharp. There's actually different shapes.
It looks like a Joseph single hook.
Yeah.
Like a round handle.
Yes.
And then describe the tip.
Yep. And the tip is kind of curved gently, kind of in the shape you would think as a crease. So you're basically holding up to the side of their face, and then you put that crease. So you actually look down. You put that kind of right where you think the crease should be, and then when they look up, it actually kind of tucks that lid tissue in, and you can kind of adjust. And I actually often take pictures of them with that so that they can actually see what they look like, or have a mirror so they can see. There's actually different shapes and configurations too, like slightly more curves. So sometimes just, person's eye socket's a little different. You can bend it too, but, and I know we can be certainly crafty. We can say, use a paper clip, like I mentioned. Some people do that all the time. They they bend it out. But to be honest, when I start doing that, the patient looks at me like, well, why are you coming with a paper clip in my eye? So this is a little more elegant, I think, and it's just really easy. I just carry it in my white coat. I even carried it down to the meeting, because you never know who you're going to see, in the airport, and they want to know how their eyelids are.
Is that really why you have it?
Yeah, no.
Other tips on practice building by Kat Burkett.
That's right. But no, I found it really useful. It's not expensive. I found it online somewhere. But it's just kind of really, I found really
super
helpful.
Useful.
Yeah, and it's not just for Asian. I mean, anybody. So it's nice to sometimes show the patient what it would look like after you if you did a blepharoplasty, but then you're trying to show them that they still have a ptosis. Because
Right.
it's kind of hard to show that
Yeah,
sometimes when you're just
absolutely.
lifting skin. So
And they have these technologies that are like the 3D virtual reality, and they can kind of make changes.
Yeah.
But I'm not sure. We looked into it, and I didn't really want to bring that in because
Yeah.
then they're going to say, well, I don't look exactly
Yeah,
like this
right.
computer said, but this is really on their face, and
this
they see
is
it live.
on their face, and it's easy, it's quick, it's not anything fancy that you have to then get them somewhere else and get that stimulate. I mean, this is like, you know what, do you want me to send you one? No, but it's really, really useful and easy. And it's like I said, anybody can use it because it's not expensive. It's not like this big machine. So
My understanding was whoever was responsible for the meeting usually sends one to the whole membership afterwards.
Well, I was not aware of that. I think I would like to double check that rule. Yes.
And then if patients are ever, upset or not paying the bill, you can kind of use it to poke them in their,
Yeah, and it's
turn it the other direction, and
that's right. Yeah, sometimes they look at me like, "What is this thing?" But it's. Oh, and I forgot to tell you different colors. There's gold handles, blue.
pink.
I would have to red. I'm not sure about pink.
Okay, all right, this is good. This is good.
Maybe we should work on that.
All right, that'll be the Burkett Samimi
Okay.
pink
That'll make a lot of money, I'm sure.
crease maker. Well, Kat, this is great. Who needs the alcohol? You're just so bubbly.
Aw.
We're so thankful that you came to join us.
Thank you very much.
Well, it is a pleasure to be here with the just recent past president of ASOPers. I don't think you need any introduction, but why don't you just say your name and how long you've been in practice and where you are?
Sure, I'm Rob Fonte. I'm in Denver, Colorado, and I've been there since 1998 when I finished my fellowship.
Excellent. And why don't you tell us the name of the instrument that you find so useful and what procedures it comes in handy with?
So the one that I would nominate for this is the number 9 periosteal elevator. And it's useful for lots of things. It's very inexpensive and indestructible. Probably get one for under $50 if you look at Amazon. I especially use it for the endoscopic mid-face lift, where you take a subperiosteal approach for that. Also use it for pretracheal brow lifts and for craniofacial procedures in general. Any sort of, even in the orbit, it works pretty well. It's larger than a Freer by maybe 3 times in terms of its width. It's sharper always, which is always nice from my point of view, and it's sturdy.
Does it have 2 sides?
It has 2 sides. The main side that we'll use is shaped like a beaver tail. The other side is sharper and is useful for small areas. It's a great device.
Do you remember what you were using before this and kind of how this
Mostly
is better?
Freer and Cottle, which still have their place too, but
Sure.
those take a lot longer. Your hand gets tired, and they're maybe good for picking an extraocular muscle out of a fracture, but not so good when you're doing a larger area of craniofacial dissection. I first learned about it from the OMFS people at Offutt Air Force Base, where I did my military service, and we had the opportunity to work together on a lot of cases with OMFS and with ENT, and they all loved it. And so then I loved it, and I thought it was really useful.
Oh, that's a good addition.
Yeah. The trade for me was I taught them about the Colorado needle, which is another useful
that's
instrument.
a good one. Yeah, that's. You sound like you have a big history with the Colorado needle, something that's near and dear to many of our hearts.
Yeah, the Colorado needle is terrific. And when I was first learning to use that back in residency, actually, so maybe even before you were, when you weren't still in high school there, David. But I was not quite sure how it worked. How is it that when you push cut, one thing happens, and you push coag, a different thing happens, and what's actually going on there? And couldn't really find any research to explain it to me, and the companies, the biomedical journals didn't really say much either. So I ended up doing a project with my father, who was an electrical engineer, and we ended up publishing a theoretical paper in OPRS in 2003 about how it actually works. And it's also a favorite instrument of mine. And as you probably know, the difference is not in voltage or resistance, but it has to do with the waveform. When you push cut, it's a sine wave. When you push coag, it's a dampened one that looks like static, and that changes the way that the molecules interact and what happens with the electricity.
Think
in the
about
tissue.
that every time we're doing our
There you
lower
go.
lip left now.
Another useful thing.
Any idea how that compares to some of the other, type of monopolar cautery tips?
Sure, there's been a lot of studies on comparing what happens at the tissue level, not so much electrically, but just pathologically what happens. And what we think is happening there is that there's a layer of ionization that happens right at the tip. And so, as you probably know from using it, you're actually better off not touching the tissue with the Colorado tip, but having it just infinitesimally above it so that you create this ionic gap there.
Kind of similar to a bipolar. You don't want to squeeze it. You want to leave it just on the side.
You don't really want to have it tightly. In fact, if you stick the Colorado needle in and use it to cut like you would a scalpel, it doesn't work nearly as well. There's a lot more collateral damage. There's more drag on the tip. You're better off keeping it just slightly out.
Good to know.
You know this. You've used it a million times. But that's why.
And are the Colorado needles that we are using nowadays, which is from Stryker, who bought the company, as far as you can tell, are they any different than the ones?
Not that I get much more expensive, but other than that, I can't tell much of a difference. I had an opportunity when we were looking into researching this to work with or to talk with the owner of the original Colorado Biomedical Company, which is an Evergreen. At the time, I was in the Air Force and stationed in Nebraska, and asked him to see if he could help fund our project, which he declined to do. And then later they sold it to Stryker, and in the meantime, the owner became a patient of mine, so that was an interesting twist.
Did you use his needle on him?
I did. I did.
So, given that you put so much thought into the Colorado needle itself and we all use it, what are your thoughts on whether or not it can be used more than once?
I'm 100% certain that it can be used more than once. In many places I go, they are re-sterilized. They can be reprocessed and re-sterilized. And I don't think there's any worry about damage there, except at the very tip. You can see if there's fraying of that the insulation that's at the tip, and there's a point where it no longer becomes useful. When we bring them, I've been to missions in other countries where we've brought those, and there's no reason at all why they can't be used dozens of times.
Sure, yeah.
And from a safety point of view, you probably know that there's a lot of talk about bipolar versus unipolar. And one of the things that we talked about in our paper was that research really doesn't support what most people believe is happening. Most people think that the bipolar is 100% safe because the electricity only passes between the two tips, and that the unipolar, which is still a bipolar, but the other pole is the large return electrode pad that's on the patient's leg or stomach, changes everything. And it's really not like that. If you look at the studies in terms of safety, in terms of the likelihood of transmission down a cranial nerve, for example, if you're deep in the orbit, there's very, very little data that supports the idea that it's dangerous.
So pretty safe in a enucleation.
There's a few cases where there's been something that's happened, but it's been very hard to attribute it only to that because there's been other, complex surgeries that involve lots of other things.
Gotcha.
So the literature doesn't really support the idea that it's unsafe to use in the orbit, for example.
What about in patients that have pacemakers?
Well, with modern
AICDs.
pacemakers, also not an issue. With the older ones, there was maybe more of a problem, but with modern pacemakers, it doesn't seem to be a problem at all.
AICD, cardiac defibrillator.
I haven't seen that. I haven't seen a problem with that myself. I know that in general, when somebody has one of those, they want to make sure that the anesthesiologist will want to make sure that they have the opportunity to intervene.
Okay, this is some good juicy stuff. Well, I know you do a lot of great surgery, top to bottom, head to neck. So thank you so much for the insight. I'm excited to try out the number 9 dissector and to think a little more appreciatively and deeper when I'm using the Colorado needle tip.
Pleasure talking to you. Thank you so much.
Thanks, Rob.
You might find it interesting to know that the original Bovie machines that were started in Boston at Harvard by William Bovie used a electromechanical apparatus that damped the sine wave, that made it so that it would be turned into static at a variable rate. The modern ones, of course, are all solid state, and they just regenerate that same type of waveform using electronics. But the original ones, there was actually a device, and they made a noise. And some of us who are old enough maybe remember some of those old Bovie machines and the noise they made when you used coagulation.
I'm sure the patients loved that, huh?
Probably most of them were asleep, but yes.
And the modern ones, I know there's a few different companies, but I mean, these seem like kind of workhorses. And there's a company, Valley Lab, that used to make a ton of them, and it seems like those haven't changed to some degree. That from you have some from the 80s that still work.
They absolutely still work, and I think that the basic design, although there's lots of competitors now, has been straightforward for a long time. And as you probably also know, there's a difference between when you use cut, they have a blend, and then they have a pure setting for that, and there's also different settings for the coag. And that's obviously very simple. It just adds a little bit of that dampening into the sine wave to make it so that there's a little bit of coagulation that happens at the same time. Useful when you're underneath the skin, dangerous when you're on the skin, of course.
And what settings do you typically use for some of the
As
most
low as
common
possible.
procedures?
I would say ideally you don't want to have the tip touching the tissue. You want to have it just above. But if you do touch and your setting's too low, it'll drag a lot. But for most people, it's going to be between 10, maybe 20 at the most for both the cut and the coag. I think in general, as low as you can go
You
is
typically
smarter.
use pure or blend?
I use pure if I use it to make a skin incision, and then switch it to blend after that.
Excellent. Thanks for the pointers.
Pleasure to talk to you.
So we are here with a legend in the field of oculofacial plastic surgery. It's my pleasure to have you on the podcast. Why don't you just introduce yourself, how long you've been in practice, and what city?
This is Jill Foster. I've been in practice for, 30 years now. I spent 10 of those in Cleveland, and I've been in Columbus for 20 years now, and loving every day of being an oculoplastic surgeon.
Okay. Good thing that listeners can't see the sarcastic face you were making when you said that, huh?
No, I actually really enjoy my job. I was making the sarcastic face about the legend part.
Well, we're excited to hear about the instrument in your tray that you like for helping with some aesthetic procedures. So tell us about it.
An instrument that I could share that's been very useful to me. It's one of the things I pull out of my oculoplastics makeup bag, like the interviews they do to say, what could you not live without? When doing endobrows, we call them the long black-handled scissors, and there's a sharp version and a blunt version. And I have no financial interest in this, but they're made by ASSI. And they have a long handle, but a delicate tip. And they are really universally helpful in doing that sharp dissection when you want to release the periosteum along the superior and lateral orbital rims, both sharply in areas where it's safe, and then also bluntly in the areas of vessels or neurovascular bundles.
And for clarity, share what procedure you're talking about.
We're talking about endoscopic brow lift.
Endoscopic brow lift.
Yeah,
Got it.
endoscopic brow lift. So when you're releasing the periosteum to achieve lift, there are different ways to do it, but this is a really safe way to do it, and also a very controlled way to do it. You can cut the periosteum where you know you're safe along the superior lateral orbital rim, and then when you get to the area of concern or protection, you can do insert the sharp end of the scissors, but then vertically bluntly dissect around the neurovascular structures as you're releasing the tissue. And it's been a handy tool that I couldn't live without in endoscopic brow lifting.
Because if you ended up having a blunt tip, it's not going to make the cut as easily.
It's not going to pierce the periosteum, exactly. So you have to get it started with those sharp scissors. And even as you're going across horizontally, releasing, sometimes you still have to make little pockets and then connect those little pockets by cutting the little pockets that you've opened with the sharp blunt dissection, or the sharp tip dissection.
That's excellent. Do you use those for any other steps in any other procedures that you know
The
of?
blunt ones I use in facelifting. The sharp ones, that's the only thing I use them for.
Okay, lovely. You kind of reminded me, because what seems like what these look like are kind of long-handled Stevens to some degree, but sharp. And I actually found a pair of long-handled Stevens curved that are thin at the end, and they work fantastic for harvesting hard palate. I just kind of remembered that.
Yes.
So this way, if you have a long kind of non-toothed forceps and you have this, it's less of their breath you need to kind of get close to when you're in there, and you're not, your hands crumpled into their mouth.
Yes, I think that would be another excellent use for those scissors. I'm going to try it out.
Yay! All right, we'll hear about that at the next podcast. Jill, thanks so much for joining us.
Thank you for including me.
So today we're going to be talking with Dr. Samimi, but I'll have you start off by identifying yourself.
Great. David Samimi, in practice for about 10 years at Aesthetica in Los Angeles.
Wonderful. Thank you, David. And what is the name of the instrument that you love and the procedures that it comes in handy for.
It's called the tunnel retractor, and it's really a game changer when you're doing fat repositioning in lower blepharoplasty.
Oh, that's something we all want to know more about. So tell me, what were you using before you found this one?
Well, I think the kind of progression in terms of just using what's already in our tray is usually, starting with the Damar, which we already have out there and we're comfortable with, and then usually the next thing is going to be, a Sen or a Ragnell, and then I went to a hand retractor, which I loved because it was a bit longer, but they both have some inferiorities to this one, which we'll talk about.
Great. Okay. Well, it sounds like you went through a whole process, which is what we'd expect. And do you remember exactly when you sort of found this and how it happened?
I do. I had my tray was missing, and I didn't have the retractor at one of the surgery centers that I go to. So my tech, who does a ton of orthopedics in this area, said, let me get you something that'll fit. And initially, I kind of frowned because, we're all kind of creature of habit, and I wanted to use my hand retractor, which was working good at the time. But he gave it to me, and I used it, and I fell in love with it. And now I essentially have one in all the offices for my office-based surgeries. I bought them all for everybody in my practice, and every time I use it now, I figure out it makes it so much easier.
I am actually very, very excited to hear the next step here. Can you tell us about it? What is it?
Yeah, absolutely. So essentially, the design of it is such that it's going to be helpful for doing the actual dissection if you're doing a pre-periosteal lift, because it's kind of like a bit of a bigger Ragnell,
yeah.
But it's angled up. And the fact that it's angled up means that it really tenses up the midface and exposes that space for you to see where you're doing your dissection and get the needle in. The other nice thing is, kind of like a Damar, it kind of has some of them have a saddle type shape, so that you kind of down the barrel of the gun, you see more in the center.
Yes.
This one is kind of like has that saddle type shape where you're kind of looking down,
yep.
And you can see it. And the fact that it has this angle that kind of comes up and it's a little tapered at the tip, essentially for my repositioning, now, once I get down to the rim, I make a little small score right at the periosteum, just in the kind of SUF, so below the orbicularis, but above the periosteum. And once you score that, and then you can either get Wes Stevens in there and just start it, or I just put this laterally into it, and given its shape, it's very thin, and it goes up. I put that in, and it does my lift for me.
Gotcha.
And then it's there, and it's holding the tissue tented up where you want it to be tented up, which is farther back. Because I had oftentimes what we struggle with is getting a big enough view with this tight eyelids. And
right.
I had a patient where I was using I think the hand retractor at the time, or the Ragnell, and I avulsed the canaliculus. Because you kind of have to pull a bit.
Sure.
What's nice about this one, given that it's kind of angled to be higher at the distal end, you can have it so that you're not pulling on the eyelid as much, but it kind of opens up. And the model number is, I only found it from this one company that makes the instrument. It's made for carpal tunnel surgery. It's called a tunnel retractor, the 10 millimeter version. It's by a company called Buxton, which I have no financial interest in. Item number 52-5563.
Well, that's great. Let me ask you a couple of other questions, because
Please.
you piqued my interest here, that's for sure. So first of all, if you could just go through your process. You're talking about obviously transconjunctival fat repositioning, right?
Exactly.
And then when you get to the arcus marginalis, just talk us through how you do this, and if you're using something to protect the globe.
Absolutely.
And then what you like to hold your suture with, what sutures you like, the whole process.
Sure. I mean, I think this part is more subjective, and there's
It's okay.
plenty
we
of
want to hear how you're doing
Skinny
it.
cat. All right, I'll talk
We all get that.
very briefly. So, however you want, transconj incision. I typically will go preceptal, have it be relatively bloodless, and then go down to the rim. I'll usually put a traction suture on the conj and retractors. It's an extra step, but it makes the rest of this all easier. And I usually have a corneal protector on just as an added kind of benefit.
Perfect.
Using the traction suture, a 4-0 silk, 2 passes to make sure that it's kind of a broad grasp, and then clamp that to the drape. And then, usually I'll use a cotton tip as my second instrument and the bovie. That way you can simultaneously kind of hold the fat back and get in that potential space right between the orbicularis and the septum, and scoot bloodlessly right to the rim.
Yep.
And then once you get to the rim, I'll do a little kind of score it's not really touching anything, but right above the rim so that you're kind of in that SOOF plane, but you're not hitting orbicularis, because as we all know, that's what's going to get a bleed.
Sure.
And so once that's done,
So you're suborbicularis then?
I'm suborbicularis.
So you're opening up
preseptal.
what they call the orbicularis retaining ligament and some or the orbitomalar ligament.
That's exactly
Okay,
right.
Just keep going.
Do that release. But you can also go retroseptal from your beginning and go in. There's no harm in that. It's been studied.
Sure.
The only thing is then you immediately
got fat in your way.
have fat in your
Sure,
way.
got
Right.
it.
But that's why I like to using my cotton tip as the retractor, so that there's the Damar on one hand and the cotton tip in your other, and then the Colorado needle, as you're so fond of. You have multiple things that are helping you retract, including the traction suture, as well as to dab if you need to with the cotton tip.
Perfect.
And then now that you've started your dissection in the right plane, having kind of scored the just above the periosteum, then I'll either take out a Stevens scissors and starting laterally, because we all know those attachments to get that plane above the periosteum immediately are tighter. So you start it laterally, and the nice thing is, we don't like using the word blind, but you can kind of very safely do a relatively blind dissection if you're pre-periosteal here. Get a blunt scissor and start it laterally, and then just move medially. And the nice thing is, if you're above the periosteum, the infraorbital neurovascular bundle, it disperses in the periosteum, and you can just kind of relatively go all the way across. Whereas if you're subperiosteal, you got to make your incision, you got to get the freers. You're kind of looking, over a cliff. And
Sure.
dissect it, and then be much more careful with
Sure.
the.
And how far south do you need to go? How far past the orbital rim?
Essentially, I go a lot more than most, is what kind of my fellows and what I see when I observe other people. And I think that helps so that you can pass your fat pedicle a little farther down. And if you're doing it as a blunt dissection in the preperiosteal plane, there's really not much harm in it, especially if you've injected local prior, so you had some vasoconstriction.
Two little details. So just to give us the rest of us an idea, is it 1 centimeter, 2 centimeters? What do you think?
I'm going to say it's probably 2 centimeters.
Okay.
Yeah.
And then right in the middle, there often is a little artery or vein that some of us have dealt with displeasure. In my area, we named it after one of my former fellows that I won't name right now. But what do you deal with that? Just cauterize it and go on?
Usually what I'll do is the two things that become an issue more commonly for me is the angular,
Yep.
once you're medial, especially when you're passing the reposition
Yep.
stitch. Centrally, the neurovascular
Right.
bundle V2. Both of those, I'll usually not freak out, inject a little bit of local anesthetic, hold pressure. And that typically will stop it, and then you're not going to have to kind of fry and,
Okay.
and go to town.
Okay. So keep going. Now you've got this all lifted up. You're ready to move your fat.
That's right. And so at that point, then I'll open the septum if it hasn't already been opened. Make your pedicles, medial, central, lateral. Make sure you identify the inferior oblique. Make sure that they're freely mobile and not tugging on it. The lateral fat pad, you can remove it, or I'll usually actually remove a small amount of it, but then mobilize it, cutting deep at the base and pulling it into the medial so you have more. And I've done internal fixation, a double arm suture, but what's most cost effective and quickest is just using a 4.0 or 5.0 Prolene on a PS2 needle, because that needle is large enough where it's very easy to make the pass.
Yes.
And so I'll start medially, definitely having this tunnel retractor in, because
Yep.
it gives you the visualization that you want. Pass it as relatively as far medially as you can, but keep
Trying
in
to
mind
avoid the angular.
The angular, that
Sure.
might happen. Pass it in, and then with that tunnel retractor, the nice thing is it kind of has that saddle shape, and
Yep.
you can then go ahead and grab the stitch. with your
Castro
forceps.
Viejo on that PS2, or are you
I'll
using
usually-
a Webster?
Either one. I kind of go back and forth, just for mixing it up.
Okay.
And then grabbing the needle, which it's useful to have a headlight, obviously for this. There's a premium to that. And then I'll weave it through the medial central fat and then externalize it. And that one I externalize really as far down as I can go, pulling the stitches out. And then as I'm tying it, I kind of have an assistant. I hold the retractor now, and I use it with a cotton tip, and I kind of, or the back of a blade holder. It's great. And then as I have my assistant kind of pull up on those two ends, that way I can make sure that those fat pedicles are tucked underneath the orbicularis.
Perfect. Great.
And nice and smooth.
Under direct visualization. Great.
That's right. And feel. And then as I'm kind of, tying that down loosely. I don't use a bolster. I stopped using it because it's just one less thing to do.
Totally
less thing
unnecessary.
Unnecessary. But leave it loose.
Yeah.
Tie it loose right over there, and then you're good to go. The nice thing is with this retractor, essentially it does your dissection partially. It gives you better mobilization and safer because you don't need to pull on the distractor lid margin so much.
Great. You're leaving your sutures a week?
I take them out of post-op week 1.
Okay, perfect. And I'm going to ask one last thing, which is how long with this retractor has it cut down, or I'll put it a different way, how much has it cut back on the time that it takes you to do this?
Probably, it's a great question. Probably, I think a good maybe 2-3 minutes.
That's worth a lot in a case like this.
Absolutely.
That's great. Thank you so much, David, for sharing that with us. This is a wonderful pearl.
Thank you for your interest. John, thanks for coming to chat with us and sharing some of your pearls.
Absolutely.
On magic instruments for the office, and who knows, maybe at home. So why don't you start by introducing yourself, how long you've been in practice, and where you are.
Okay. Name's John Martin, and I am down in Miami, Florida, Coral Gables, and I have been in practice since 1987, which is hard to believe, since I use all my rejuvenation machines in the office, so I don't look. Trying to stay looking younger.
You don't look a day past 70. You're doing great. So tell us about this instrument that really has changed the game for you.
Okay, for several years I have been using a vibrator for anesthesia. And lots of different vibrators on the market, but when you use vibration, several studies have been done to show that people prefer vibration to either ice or to topical anesthetics because it works better. So if you use the vibration, what it does is it sends an inhibitory fiber to your pain sensation fibers. So for most people, it'll block the pain significantly. You might feel a little bit of discomfort, but the pain is nowhere near what it is without the vibration. So for example, in my office, I don't use any topical anesthetic for fillers. All we do is the vibrator, and you can even do an upper lip with nothing. You just put the vibrator, I do it right in the middle of the lip, and then just kind of cruise along and fill in the lip.
That's impressive, given that that's one of the most
It's so
sensitive
painful.
areas.
And even patients will say, oh my gosh, this is so much less painful than anyone who's done it before.
And then do they go to their friend and say, he put this vibrator in my mouth, and I never felt better.
And the first comment when people have been there before is you walk in the room, they go, where's the vibrator? The other thing that I do, some people will put a vibrator kind of in a distant location. Like if they're doing the lip, they'll put it on the neck, which to me doesn't make any sense.
Right.
Because if I'm trying to override the pain fibers from the spot I'm working, I put the vibrator very close. So,
And obviously you need to have an assistant
Right.
with a vibrator,
or I have the patient hold it.
That's a good idea.
A lot of them are very happy to just hold it, and I just sort of have them move it. It gives them something to do.
Totally.
Their hands vibrating, the lips vibrating, or whatever other area you're treating is vibrating. It has totally changed my practice in terms of pain control.
Well, I love the idea that the patient can do it, because right now, I just kind of use my finger to jiggle it
Right.
so that you don't need to wait for an assistant to be in there. But having them do it, that's great.
And I do jiggle, let's say, with toxin injections, because they're not that painful.
Sure.
But the fillers are a little bit more painful, so this has really made a huge difference. Or anesthetic injections that burn a lot. You use some vibration, it really cuts down
Oh man, I'm
tremendously.
sold on that for the local anesthetic for in-office procedures.
Do it. All right, so one of the nicer ones is called the Beauty Bar Golden Pulse Facial Massager.
Okay.
And you can get that on Amazon. It's about $10. Takes one AA battery. The other one I use is something called a Pocket Rocket, and it vibrates a little more vigorously. It's just not as pretty a vibrator.
But it has a better name. Great. Well, you might get the award for best value.
Well, the best was the patient who said, "Oh, I have one of those at home." I was like, "Okay, too much information."
See you later. All right, this was great. Thanks so
Okay,
much.
absolutely.
Appreciate
I'm
it.
telling you, it will change your practice.
Great. Well, it's a great pleasure to be here with one of my mentors. I mean, you kind of, Mastery says he did a second fellowship with you, and he's been a mentor to me, so it's really nice to have you here to chat about some of the instruments that you love. So why don't you go ahead and introduce yourself, where you're in practice, how long you've been practicing for.
Well, thank you, David. John Holtz. I'm in St. Louis, Missouri. I trained with Rick Anderson 87 to 89 and spent a year in Austin, Texas, and then came to St. Louis. I've been there since 1990 in practice. And in terms of instruments and special things, and I don't really typically design that many special things. I tend to just find things that work and try to use them. A couple things. I'm just going to mention a couple instruments. I'm more of an anterior than posterior ptosis surgeon, but I do think that modification of Steve Dresner's clamp. So I used the original Putterman clamp for years. In fact, I still have a vintage Carl L. clamp that I hang on to and make sure it doesn't get abused by anyone. But I think his clamp was nicer, the E2512 in the store's catalog. And then the more recent modification I think you told me about was the SP7-70736. And that's just a further refinement of that clamp, and I do think that's the preferred instrument. I can do it with any of them. I do find it hard to do this surgery with clamps that are not like name brand clamps. So most of the ones I bought that are kind of overseas manufacture and a whole lot cheaper don't tend to hold the tissue well. They slip. And
so what are the benefits that make you like this modified Dresner clamp?
I think it's a little less in the way it's designed. The handle's a little less in the way. You can sort of get inside, get the work done. It's very secure in terms of how it hangs onto the tissue. And again, this is a procedure, since it's not sort of my main go-to, I kind of like to at least feel like I'm doing things as repeatably as possible anytime I do internal ptosis.
It's interesting that you say that it's a little easier to kind of hold. The benefits that I kind of see. I never necessarily thought about that component, but it's that the teeth are a little bit smaller and they're moved down closer to the edge of the clamp. That way, if you're trying to do like small, 4 or 5 millimeter muleirectomies, or a 2 millimeter fascinella to do an adjustment of 1 millimeter of ptosis, you can't do that with the current clamp.
Oh yeah, no, and I remember your talk some years ago about your little touch-up technique, which is spectacular. Yeah. So,
and the other thing that's nice too is that the at rest it's closed, where the other kind of Putterman type clamps, at rest they're open, and so you need to kind of push it closed. Whereas this one, when you let it go, it's kind of has a reverse hinge fashion.
Yes.
And then you can adjust the crush so that if you're trying to do a fascinella, you can only crush it a little bit. Whereas with these other clamps, you need to kind of put your thumb down and it smooshes everything.
Well, there you go. There's a posterior master speaking. So
I don't know about that.
So you apparently go to the dark side frequently.
Yeah. The circumcision, yes.
Yes, you're an eyelid circumcision specialist. And the other instrument that I've sort of used since I started fellowship, because I worked with Rick Anderson, I could sort of tell you all his favorites, and one of them was the Paufique forceps, Paufique, Henri, and the E1831 in the store's catalog. And they made that instrument absolutely identically, probably for over 50 years. And then Hans, or whoever made it for him, must have retired, and the new person decided he was going to change it all up, and it got these giant, snaggly crocodile teeth on it. And
my suspicion is that probably, because General Plastics also uses facial plastics, and they probably gave some feedback. These teeth are too small, not realizing that it's used primarily on eyelids.
Yeah, and it's unfortunate, because I think stores made probably the preferred version of this clamp. I don't work for them. I don't get any money from them. I give them extra money to get it modified, because now I have to order this instrument with an SP7-70197 modification. But that does get you a tooth profile that is original, so paying extra, I can now get what they should be making, in my opinion. But, that forceps is super nice. It's got nice teeth that you can hold heavy tissue, light tissue, very occasionally. I mean, it's almost like I have to have a 0.12. I'm sewing thin conjunctiva before I ever have to put down the Paufique. I can hide it in my hand, so it never leaves my hand the whole case. I just turn it backwards and hold it with my pinky and have it in my hand the entire case. So
that's because it's smaller than the Castro Viejo.
It's short.
It's
shorter.
about 2/3 size.
Yeah, so it's shorter.
The other thing that is nice about the Paufique, correct me if I'm wrong, is that it has a tying platform.
Yes.
Which a lot of the other, sutures, forceps don't. And then it has a little bit of grip to it, which I think it's similar to the Manhattan, but the Manhattan doesn't have a grip on it.
Exactly. It's got crosscuts on it, so it's got a stippled handle that gives you a little more grip. And you're correct. The Manhattan is smooth.
It's smooth. The other thing I think for our kind of listeners to feel in mind, I think the other reason why people like it is because, and Dresner loves it. He trained with Anderson as well. Is that given that it's a bit shorter, it allows your hands to be closer to the surgical field when you want to use your pinkies and other stuff to retract.
Oh, absolutely. Yeah, and that's a big deal. I mean, I've had trouble because my surgery center keeps ordering the Fraser suction tips with about a 10-inch tip on them. After the bend, it's like 10 inches. So, and I end up taking them over to my office. I cut them off. I polish the tip. It just makes a whole project for me because I don't want my hand, a foot from the patient.
Yeah.
So anyway, moving on, endobrow. I have seen and done about everything. I started doing this operation, I think, in 1994 when it was pretty new. I was asked by somebody to teach them how to do it because they thought I knew how. And I said, well, I've never done one, so I'll do it with you. And I got Roland Daniels' video from stores, old VHS tape, watched it twice that night. And
now you're ready to teach it.
Went in and... you learn a few things and so on, but the operation as it started out, the classic procedure is still about the same. And I used for some years externalized screws. I tried the endotines. I've used those. Between the cost and just sort of the ability of them to persist and cause issues later with the patient. The patients get pain from them sometimes. I sort of abandoned those. I went back to screws. I tried a Sykes bone bridge. I decided I was going to quit doing screws and couldn't find a Sykes bone bridge to buy. And I said, well, I can freehand holes and,
Sounds like you didn't love any of these because it kept evolving.
Yeah, I kept it evolving. The externalized screw sort of did the most cases over the many years. But I sort of saw, okay, bone tunnels are probably where it's at.
Sure.
And you leave a piece of suture in, but you don't have anything else left behind.
Yeah, no hardware.
But all these other devices are either cumbersome. The bone bridge, you got to create a much longer incision. The endotine costs a lot and has the issues as it persists and gradually degrades. So, and one of our colleagues, uses a good size, probably 2.5 millimeter drill that they actually make these big, freehand tunnels. And I'm not doubting their skill or anything, but they've got.
But there's a big learning curve on that one.
There's a learning curve. You got to route out bone. They pass the needle through this. And I thought, okay, there's got to be a better mousetrap. And Hayden Medical has a drill which, for some reason, he catalogs as an orthopedic drill. I guess he just doesn't want to take ownership of using it in endobrow, even though I don't think you need a IND to use a device in that fashion. But it's a 5 millimeter stop. So you wouldn't want to point it square into cranium because you could punch through somewhere.
At an angle, it's okay.
But if you angle it 45 plus degrees, and you have to start it almost vertically just to get purchase and get a little dimple in the bone, and then you can start gradually rotating it. And drilling for many years, some people just hit the drill and go at full speed. I always kind of pulse it, go slow, irrigate. And if I ever see smoke, I know I've kind of overdone it because there you got burned bone. You're going to have necrotic bone, and you're overheating your drill, which is what dulls it. And even though this might be a single-use device, I might have done well over 20 cases with one drill. And if you treat them right, they don't really get dull too fast.
Kind of like the Colorado needle.
Yep, kind of like a Colorado needle.
So this drill is a bit that you use to then make a more safer, shorter bone tunnel for your brows.
The bone tunnel has a width between the two holes. There's maybe less than 3 millimeters of bone.
Got it. And you're freehanding both of these sides?
I'm freehanding both sides. So I just angle in one side, angle, try to get to where I'm within about 40 degrees, less than 45 degrees of the bone. I get as flat as I can get to the other side, about 3 millimeters between where the drill holes are, angle, connect, irrigate, make sure it connects. You know, the little span, the little bridge of bone is probably only 1.5 millimeters thick. It's really thin.
Did you say
never seen one break?
Did you say which needle you use to fixate through?
Yeah, so I've been using a 3.0 PDS on a
P3?
No, it's I can't remember if it's an RB1 or it might be a PS2. It's some fair size.
Okay, and then I think anybody who does a lot of brow lifting kind of figures out the reason why you should have, even if you're doing just temporal lifting, correct me if I'm wrong, some kind of fixation device for bone is that if you're depending on suturing into deep temporalis fascia, you can really only pull the brow laterally. Different on some people because the conjoint tendon ends, and if you want to get a vertical lift, you got to have something on bone.
Yeah, it's hard to do much vertical lift temporal. You are correct, and if you do too much expansion, I know that the ethos in brow lift has changed. A lot of people don't release the center at all anymore, and certainly there are reasons because of neuralgic pain, and so forth, to not do that. I think the splayed brow is kind of overstated unless you just go crazy avulsing muscle. I mean, if you say I'm going to get every single corrugated fiber, no matter what, and you're going between the nerves and the skin and ripping everything out, yeah, you can splay a patient.
Fantastic.
Otherwise, it's hard.
Well, John, thanks for all those pearls, years of experience. We appreciate it.
All right. Well, love you, and always like to see what you're up to, David. All right.
Thanks, man.
Okay.
Always like to see what's in your tray.
Yeah.
Take care.
Okay. Thank you.
So I'd like to welcome another esteemed colleague in our society who's bringing a lot of other multidisciplinary approaches and stuff that we do. Why don't you start by introducing yourself, how long you've been in practice, and where you're in practice?
Great. Well, thanks for having me. My name is Tanuj Nakra, and I practice in Austin, Texas at TOC Eye and Face. We're a larger oculoplastics group, and we specialize in the full spectrum of eyelid and oculoplastics as well as facial cosmetic surgery.
So everything is bigger in Texas, even oculoplastics.
That's true. That's true.
So then let's just start, and you can tell me the name of the instrument and what procedures it's used for, and then we'll get into describing a little bit more later.
Sure. So in facial surgery, one of the challenges that I've found in my own evolution as a surgeon is releasing tissues. So for example, when performing a brow lift or a facelift, you have to get ligamentous release of the osteocutaneous ligaments to be able to manipulate and move soft tissue structures on the face. And traditionally, release in a brow lift would be done by blunt dissection with a scissor or a sharp instrument releasing the tissues in the brow region. As I have become more experienced and maybe sophisticated in my brow lift techniques, I've tried to find more ways of really getting that release accomplished safely, efficiently, and frankly, very effectively to get the maximum release, because it just makes the surgery easier when you have that ligamentous release to be able to then put the brow and the temple where you want it to go.
Sure.
So,
and do you use it both for when you're above the deep temporalis fascia, or do you also use it when you're subperiosteal over the forehead?
So the instrument that I'll be talking about is called the TrepSat. It's kind of shaped like a Metzenbaum scissor that has horizontal plates on the front tip of the scissor. So it's not actually a scissor, but when you spread it open, the plates separate up in a vertical direction. It creates space between planes. We kind of jokingly call it the platypus because that's what it looks like when you kind of open his mouth up and down. And so the TrepSat is a very effective way of creating release between tissue planes. And because the round plates are fairly wide, it distributes the tension over a larger region so that it reduces the risk of nerve injury or penetrating past the plane that you're trying to stay in. And so I'll use the TrepSat when I've completed most of my dissection, or actually no, when the dissection is complete fully, down into the lateral orbital rim region, past the temporalis, taking a deep plane under the intermediate or Yassegal's fat pad, I usually expose the anterior third of the zygomatic arch and come down onto the malar.
So to
eminence.
be clear, this is during endoscopic brow lifting from your temporal approach incision.
Yes, that's correct. Yeah. So during an endoscopic brow lift, temporal incision, not necessarily even needing a visualization because you're kind of past the point where you can really see with the scope.
Yep.
And I'll use an elevator, like an Obigeser or a Cobb elevator, to do the release in a subperiosteal plane. And oftentimes it is a blind dissection as I'm going past the orbital rim and past the lateral canthus with that elevator. I'll oftentimes release the lateral orbital retaining ligament, and basically pretty similar to what would be a mid-face release.
Sure.
And coming down even onto the masseteric attachment, because that's a very tight tether for the face. And once I've got that space created, now I need to stretch the tissue planes. And because we're subperiosteal, yes, there's a lot of facial nerve branches coursing right above the plane, but the trapsat slips right down into that pocket, and we just crank it open, and you can literally see the entire cheek release, and you can hear sometimes even a little snap, which is a combination of satisfying and disconcerting to the uninitiated.
Maybe we'll bring the microphone into the OR with you and get that sound and clip it in here.
But once that happens, you can literally grasp the edge of the temporal incision and lift the entire face, and the gel will move vertically upwards. So to me, that really becomes kind of a complete release.
It's kind of an upper facelift.
It's an upper facelift, yeah. And actually to go even further, the facelift conversation, when I am doing a facelift, I now will basically for all facelifts, at the very minimum, do a temporal incision and do that dissection and release with the trapsat. But more often than not, I'm doing a full endoscopic brow lift in conjunction with the facelift because it just makes sense. If you're lifting from below to avoid bunching of the temple,
absolutely,
you got to lift the temporal region at the same time. And
at what point are you transitioning to subperiosteal?
So, that release of the midface is a subperiosteal release, and then the trapsat releases the zygomatic cutaneous ligament from a subperiosteal plane. And then I use a high SMAS deep plane approach for facelifts, and I will make an incision to SMAS from just anterior to the lobule to the lateral orbicularis, and I will then dissect under the zygomatic cutaneous ligament from the soft tissue approach laterally. But because I've already done the subperiosteal release, it allows that elevation, identification of the ligament, and accurate dissection to occur more efficiently and accurately. And once I get through the ligament, I actually don't really need to open it further and visualize it, because at the end of the day, why are we releasing that ligament? It's to...
Which ligament are you talking about?
The zygomatic cutaneous ligament.
Sure. Right in the center of the midface.
Mm-hmm. And we're releasing it so that you can get full SMAS release and elevation. And so once I'm past the ligament in a facelift, I can then slip a Metzenbaum scissor over the zygomaticus muscle, and then it'll enter the pocket I already created, so that I actually can tap, again, this will be good for a podcast sound effect, you can actually tap the Metzenbaum scissor onto the maxillary face and kind of get that satisfaction of knowing that you've connected the pockets. And then you can even rotate the scissor so that it's spreading vertically upward in that tiny little hole, and get even additional release to make sure you have a full mid-face release. And then at that point, lifting the SMAS pulls the gel up in a dramatic way, and
especially if you release the mandibular cutaneous ligament.
Yes, which I usually do
initially.
As a side note. From a submental approach, I'll release it subcutaneously. Is how I generally manage that.
Yeah, absolutely. So, do you use the trapsat when you're actually in the midface as well, or usually when you're from the temporal and that's it?
Yeah, the trapsat is for me primarily a sort of that massive release tool in the midface from above. I also use a trapsat in a facelift when I'm doing subplatysmal dissections from a lateral approach.
Sure.
I do like to at least visualize external jugular when I'm releasing the platysma, and the trapsat provides such a safe way to open that plane up.
Make a pocket to
create a pocket, expose it so that I can see it, and avoid it when I make an inferior back cut on the platysma, and then it allows for lateralization. And so the trapsat is very good at opening up tissue planes that don't have a lot of tethering for a facelift, but then again from above for the brow lift.
Yeah.
So I would say that, in my evolution as a brow lift surgeon, the TrepSat has made a huge change in my technique, my results over maybe the last 4 or 5 years since I've been using it. I should absolutely give Brett Kotlis in New York City credit for telling me I have to buy this instrument. And he sent me a text message, 4 years ago with a picture of the instrument. And
oh, that's great.
Yeah, I think it's
that's great. I had earlier in the facelifting career, but learned the Giacono extended deep plane, doing all the releases like a metacutaneous, mandibular, and cervical retaining. And they use essentially Aston scissors, which are designed for spreading, and a lighted retractor. And that lighted retractor is providing the tension, and then the scissors kind of goes right to that plane and kind of opens it up. But the scissors certainly are smaller. And so there's a facial plastics guy, Dr. Kian Karimi, who we operate at the same place, and I got it out of his tray, the platypus retractor. And it just makes things so much easier. And it's also less strain on your hands to use and doing it with a scissor than you're kind of doing with that.
That's right, yeah. And I think when you're working in the deep plane with the TrepSat, which I do occasionally, you really feel very confident.
Very safe.
This is a safe maneuver. It's not going to injure a facial nerve. It's just not going to happen.
It's safe while being powerful, which is nice.
Any surgical instrument that can do that is worth its weight in gold.
That's great. Well, on that note, there was some fantastic, very advanced facelifting pearls dropped here by Dr. Nakra. Thank you so much for coming.
My pleasure. Thanks for having me. Enjoyed it.
Thanks so much for joining us on this cosmetic edition of What's in Your Tray, so you can up your game in the OR and beyond. Well, as they say, a picture speaks 1,000 words. So we actually have photos of many of these instruments and the surgeons using them. Go ahead and check out the episode notes, and you'll find some information on where you can see these pictures. We'd love to hear from you and have you participate in a future episode. Check out the show notes where you'll see my contact information, and you can send me your favorite instrument and hopefully participate in a future episode. So again, thanks for listening, and we'll see you on the next episode of TOP.
Thanks for listening to TOP, the Oculofacial Podcast. We welcome all new listeners and invite you to tell your friends and colleagues about our podcast. If you're an ASOPRS member surgeon or trainee and are interested in hosting a podcast episode, please submit your idea by clicking the link in the episode notes. Next time on TOP.
Hi, I'm Nick Mahoney, and on the next episode of TOP, I'll be talking with Kat Burkett about the Fall Symposium, all the preparation that goes into it, and all the fun that's had.